he was basically saying this is a disease, having vitreous floaters is a disease. It's not just something that we should just watch and wait and be hopeful about. It's something that's really affecting patients. If you look at what happens in ophthalmology, and this will be controversial, but that's okay. We wait, if you look at standard of care, we wait until a patient goes from being a little bit sick to being very sick before we treat them. Still 90% of ophthalmologists won't talk about nutrition or macular pigments, even though we know that they're highly effective, because they'll wait until a patient hits level 8, 9 and 10 on the ARID scale, and those with cardiovascular degeneration that they'll inject. So it's test, retest, and now you're sick enough, come to my clinic. And I'm not being critical of medical ophthalmology. This is the system they work within. The issues is that the access that we have to micronutrients in today's world is a big problem, not just for the macula. It's clearly a problem for general health, cardiometabolic disease, diabetic retinopathy, all of these. It all comes back to foods. It all comes back to how we live. It all comes back to what's happening in the food industry. And unfortunately, Martin, it's not a very good picture. In a world where we over-farm because we need a lot of food for people, and we select particular crops, and we use pesticides, and we store in a certain way, by the time it gets to our fork, we're really in trouble here.
Now, in this video, I had the pleasure of sitting down to have a chat with Professor Nolan about his work on eye health nutritional research. We cover his past and present work on eye floaters, macular health nutrition, and we also discuss the state of eye health research as a community. It's a rare and candid discussion with a leading vision nutritional scientist that I found fascinating as an optometrist, but I also tried to ask some of the questions that I get asked by you guys. So hopefully you find this video interesting too. It's definitely a long video, but I'll drop timestamps below in case you need to revisit this video and watch specific chapters at a later date. Thanks so much for watching. Enjoy the conversation. So I want to welcome Professor John Nolan to the channel. Thank you so much for joining me, Professor Nolan. Now, I think you're working away in America at the moment, aren't you?
I'm actually I just got back. I was in Denver last week at a optometry conference, Vision Source conference, and I was actually in France the weekend at an ophthalmology conference at the. And believe it or not, I was speaking at the International Floater Society meeting as part of the National Ophthalmic meeting in France. So it was a wonderful session on Vitreous and what we're all doing in that area. So it's great to see that it's part of the agenda.
Yeah, phenomenal, excellent. And we'll definitely get onto some of that a little bit later on. So, I mean, I know that you're a well-known and respected scientist, but I'd love for you to just give us a little bit of an introduction to yourself and the work that you're doing.
Thank you, Martin. Yeah. I'm a scientist. My primary degree is in basic science, moving into kind of biochemistry related science. So analytical chemistry as well would have been a lot of my interests. So how we measure micronutrients essentially. But then I kind of moved in for my PhD studies. I conducted a major experiment on macular degeneration. And essentially profiling people at risk of macular degeneration. And this was where we identified that nutrition is a major determinant of one's risk of whether they develop macular degeneration or not, and connecting that to the macular pigments, which we'll come to. And then I suppose I had the very good fortune of moving to do my Fulbright scholarship in the US. Working with some of the best scientists in the field of macular pigment research. And that was where I really fell in love with the study of nutrition for human health and function. And of course, that was in 2005, I went to the US, so a long time ago now. But technologies were only becoming available in eye care. I think I was one of the first to use OCT at the Medical College of Georgia. So that's it, the technologies have changed what we've been able to do. But I returned then to, as was always my ambition, to Ireland, to the southeast of Ireland, where I work at. Then it was Waterford Institute of Technology. We've since become a university, the Southeast Technological University. And I established from a group that I had set up called the Macular Pigment Group, I established the Nutrition Research Centre Ireland. And this is a multidisciplinary group of researchers of all disciplines: optometry, ophthalmology, epidemiology, statistics, nutrition science, analytical science. And putting all of this together, we were able to develop protocols that became very useful and, I suppose, successful in conducting nutrition-related research for eye health. And our particular interest was visual function. Of course, macular degeneration remained important, but really, with key partnerships, we were able to kind of bring in expertise and study nutrition of the eye, but how that relates to visual function. And that all of that work over maybe 15, 16 years led to a major fund, which was the CREST Central Retinal Enrichment Supplementation Trials. That was funded by the European Research Council, which ended up being nearly 2 million euros worth of research funds to conduct a major study with the macular pigment carotenoids and how they impact on macular pigments, but also on vision for the healthy population and for those with early stage age-related macular degeneration. So that was really, really kind of a major turning point. And we had great support over those years from a foundation in the UK, the Howard Foundation. Dr. Alan Howard, well known for his scholarly works in the Cambridge diet in the UK. And he supported a lot of our work at the university and people at the university. And I now function as the Howard Chair in nutrition for at the Nutrition Research Centre Ireland. And it was along this time then that we had the opportunity to extend our research questions beyond that of the retina. We've done a lot of work with cataract, visual function in cataract, but we started to look at this wonderful tissue called the vitreous, and just similar to the macular pigments. You know, because at that time I was working with ophthalmology, who were not that interested in nutrition in the eye, to be honest. Similarly, looking at the vitreous, and I kind of had to take a step back and go, wow, the vitreous is crucially important to everything we're trying to do here. But we tend to ignore the vitreous. We tend to, I think the works from Jerry Sibak, who I'm sure you're familiar with, he suggests that we must look at the vitreous and not just through it. So we must look at it and understand it. And we've had some key discoveries with the vitreous. And, in many ways, the vitreous is invisible by design. We only kind of start talking about it when there's problems with it. But maybe just like with our macular health, we should do a lot of work earlier to protect this really important tissue that gives us the optical system in which we work within.
Yeah, fantastic. I think I very much agree regarding what you said about the vitreous. Often we just think of it as this, a bag of fluid that doesn't really do anything, has no kind of relevance beyond the embryonic stage, and don't give it that much thought. I mean, that might bring me on to a question of, what's kind of eye health research kind of community like at the moment? How vibrant is it? And often as professionals working on the front line doing primary eye care, you kind of lose sense, I guess, of what research is going on and whether there's new kind of research coming online. Patients have questions and ask you questions about the development of treatments for certain conditions and things. So generally, what's your sense of how that community is?
Yeah, I think it's a great question and a timely question. Honestly, Martin, when I started my work with the macular pigment in the macular pigment field, the concept that nutrition and maybe a lutein or a mesozeaxanthin supplement and so on could be of benefit, it wasn't really entertained. And then we had the ARID study, which was a study looking at disease progression, morphology, and that added a lot of value. But the science since then has really escalated in the macular pigment world, to the point that it is now without doubt that using targeted, tested, safe nutrition to enhance the health and function of the macula is something that eye care has to be doing, and not just when we have a disease. And to answer your question, what's the community like? I'm the founder and co-chair of the Brain and Ocular Nutrition Conference. We have an event coming up in Boston this June, and this is a very interesting group because I probably, like a lot of your kind of eye care colleagues, would have attended the Arvo convention, which was like over 10,000 people talking about eyes and all different facets of eyes. But again, nutrition was not really part of that conversation. It was driven by interest around surgeries, treatments, pharmaceutical. That's what governs ophthalmology. But we did manage to have, thanks to wonderful scientists from all over the world, a little session, a poster session at that big famous conference. And, you know, I went to my first one 25 years ago, and I went on 10 years I was getting ready every year to go to this Arvo convention. But thanks to the support from the Howard Foundation and Dr. Alan Howard, and my own interest, we decided to kind of create a community within our scientific world around that was kind of focusing on just the study of kind of lifestyle nutrition for eye health and brain health. And that was when the Macular Pigment Conference kind of evolved into the BOND, the Brain and Ocular Nutrition Conference. So we have about, like, it's a very protected species, you know, of us scientists, maybe there's 6 labs, you know, it's small, that are really kind of set up to do some kind of research in this area. There's probably 120 scientists studying this today, you know, and a lot of them will work with me directly. And then there's Paul Bernstein has a wonderful laboratory in Utah. So there's lots of other kind of PIs like myself, and we've thankfully been able to work together to create the future science. So we put a lot of effort into the Bond conference to allow new ideas, new researchers that want to study nutrition. And then thankfully the work on the Vitreous has become part of that. You know, it was probably presented, in fact, at the Bond maybe in 2018 for the first time. And it was only really in 2022 and thereafter that the major publications, 21, 22, that the major publications on our work on the Vitreous became of interest to people. And then when you look under the bonnet, you see similarities, you know, and people doing maybe relevant work, but in other areas. So, for example, Professor Jerry Sibak, or Dr. Jerry Sibak, whose his book is here. Here's Jerry's book. You can see the Vitreous, so a lot of reading there, but Jerry's teaching here in a parallel universe to what we were doing. We're similar in that he was basically saying this is a disease, you know, having vitreous floaters is a disease. It's not just something that we should just watch and wait and be hopeful about. It's something that's really affecting patients. And the commonality was, when I measure vision in patients, I look at the totality of vision. So I look at contrast sensitivity. And so was Jerry. He was doing that at the surgical space. And that was where we kind of... So then we collaborated with Dr. Sibak, and we had a PhD program that was funded by Abiga Vision, which were the commercial company that works with our university. And I should maybe do those disclosures in a bit if you'd like, about what that means.
Sure, yeah.
But we thereafter had access to study micronutrients of the vitreous, all leading through an interventional double-blind placebo-controlled trial, which was the FLIES trial. And I can speak about that particular study if you like, and what that showed. But the point is, you know, there's a lot of work being done, and I think if you look at the data, you can see that there's an exponential increase in the study of vitreous, nutrition of the vitreous vision. There's some great work done in the UK. A scientist who actually is a floater sufferer, Stuart Hayward, did fantastic work, in my opinion, on quantifying the effect of having floaters on visual function. And he did this by quantifying their effect on back scattering. Okay. So while what may appear to be a very small opacity under objective assessment can have a major effect on your patient's vision-related quality of life. So there,
fantastic. I mean, that's helpful to know, and helpful to get that insight into what is really going on. I know sometimes some of the sufferers of certain conditions that I speak to, do feel desperate, do feel that there's a sense of being misunderstood by the
Yeah.
profession and not enough is being done. And
Yeah,
that's,
and
that's I guess,
just could I add to that because
yeah.
I think that's important. And I think what you pointed out here, something that I'm very cognizant of, is the
Mm,
sensitivities. So there's two types of sensitivities. One is whereby a patient feels unsupported by the eye care professional,
hmm
and because the eye care professional, in theory, believes there's nothing that can be done. Now, I disagree that there's nothing can be done. I think there is something can be done. And equally, when someone like me and my colleagues publish a paper and we're very excited about it because it's you hit your primary outcome measure, equally we must be sensitive to the fact that there's still lots of unknowns. In our own
hmm
flies trial, 30% of the patients didn't experience the improvements. So
Yeah.
then the question is, why is that? And I saw, you know, within your own channel, I was alerted to, understandably, careful skepticism around, what we were saying. And I've had this experience my whole research life.
hmm
Anytime we discover something, the first thing people do is they say, oh, it's a small study, or, it needs another study. And I'm going,
hmm
oh, okay, but like, let's look at the fly study, for example. Sample size 61. So
hmm
small sample. In medical ophthalmology, they wouldn't even consider that to be important. I'd argue that's a whole other podcast, and we could talk about statistical power and impact.
Sure.
But the point is, we didn't just do the flies trial. There was 10 years work done by Abiga Vision and their scientists
hmm
studying the formula, testing it with, general ophthalmology, looking at patient response, understanding that. So there's been hundreds and hundreds of patients, tested now with these micronutrients. And the key part to this is that, and when I give the presentation on this, I try to explain that maybe we were all taught that the vitreous is a closed system.
hmm
And once it's locked in, right, from it's we're born, the
Absolutely.
eye develops, and we have no, that's not correct.
hmm
There is a massive metabolism within the vitreous,
hmm
and the micronutrients within the vitreous, which includes, for example, vitamin C and other bioactives, are metabolized and they have to be replaced, and therefore we must be providing them. And so there you have your, through the ciliary body, you have your transfer of micronutrients, and there's a lot going on there. So
Yeah.
changing that basic premise, or challenging it that it's a closed system and saying it's not, and therefore we can get access to the vitreous with nutrition. Of course we do.
hmm
What if we get that right? And if you think of the job of the vitreous, we said already it's invisible by design. So
hmm
now we should talk about light. Okay, this is really where I think the discoveries are, because, and back to Stuart's work as well. What you want is that the wavelengths within of the collagen fibers and the hyaluron
Yeah.
and everything that's in the vitreous, it's mostly water, are less than that of the light. So the light
hmm
therefore can pass seamlessly through the vitreous and do its job of getting to the photoreceptors, and then we have vision and we
Yeah.
can all see, and we don't have these, conglomerates in our way.
Yeah.
That's fine until it isn't. And the
hmm
second you have a small change in wavelength of any of the constituents that comprise the vitreous,
Right.
means that the wavelength changes. If an oxidation of collagen will
hmm
change the configuration and therefore the wavelength of that. And that is what I believe is causing the dramatic impact on patients that suffer. So it's not just that we look with an imaging technique, which we can do
hmm
and say, oh, look at the horrible floater because we can see it, or you see someone with a PVD, and that's
Yeah.
obviously at the end stage. But the effect, I believe, based on the patients I've worked with, can may be very high in an individual, even with low levels
hmm
of conglomerate vitreous floaters,
Yeah.
and therefore, if we can do something to counteract that with enzymatic, anti-glycative, antioxidant micronutrients of the vitreous, it makes sense from biology perspective that if you keep the equilibrium in a better way, a subtle
hmm
change in improving it could have a great effect on the vision. And that's what I believe the case to be.
Yeah. I mean, that's fascinating. That's some really helpful insight actually in terms of how we think about first of all measuring and quantifying the I suppose the quality of life impact that somebody might experience based on whether we see that they've just got a couple of floaters, and how I suppose in practice we can easily quite dismiss these individuals, but they're saying, well, actually I'm going through quite a lot here. But the fact that you're talking about the impact on I suppose the whole I suppose the clarity, the optical qualities of the vitreous can be transformed by, like say, a fundamental change in the micronutrients in the vitreous, and I guess you're saying it's things like contrast sensitivity where this might show up more on and things rather than.
It's not that it might; it absolutely does. And so Martin, you're a practicing clinician, correct?
That's right. Yeah.
So, and I know how busy you are. So how do you measure vision in your clinic?
For the most part, it's Snellen.
Yeah. Okay.
You might, if you feel if you feel quite motivated or inclined, or if you see there's use case, you might do contrast sensitivity, particularly on things like cataract patients.
Yeah.
But yeah, I mean,
But
certainly
typically, you
I might
probably
consider
don't.
on floaters. Yeah, typically you
Typically, you
don't.
probably don't.
Yeah.
And that. So let's just kind of unlock that for a second. So you're looking at something that's is it 160 years old? It's measuring vision at 100% contrast. It's not indicative of your patient's vision, regardless of disease.
Yeah, absolutely.
So you're absolutely right. I believe that the interaction with your patient, how do they feel about that's one piece of the assessment. That's really important. And then if you you mentioned cataract, so we published a lot of papers with patients who were telling their doctors that they were unhappy with their cataract, and the doctors will look at it, measure acuities, and it didn't hit the threshold for cataract surgery. So those doctors let the patients leave the chair unhappy. Now, what we showed is if you measure their contrast sensitivity, it's the first measure of visual function to fall, whether it's macular degeneration, cataract, vision degradation, myodysopsia, as in vitreous floaters, any of these conditions. Measuring vision correctly is crucial to what eye care understands. I've been talking about this for over a decade. So that's why when we do our clinical studies, our primary outcome measures are typically contrast sensitivity, 6 cycles per degree. And Oguzie and Sloan's work published, can't remember the year now, but a long time ago, they did an assessment of vision-related quality of life and measures that correlate to it. And age, they looked at everything. Contrast sensitivity was the highest determinant of vision-related quality of life. So we've known for a long time. And the technologies are there. It's actually very easy to measure contrast sensitivity.
Yeah.
And if you look at the FLIES trial, before we went and did our interventional work, we did a lot of cross-sectional studies. So we looked at patients with and without vitreous floaters that were suffering, so age-matched controls, and we looked at their visual function. So we worked with Professor John Barber. He's a City University in London, and he developed technology actually to measure visual performance for pilots and high performance vision. So we use his technologies. So we're looking at contrast thresholds, and we're looking at everything you can do, different light conditions, photopic, mesopic situations, so on. And very clearly we see that patients that have vitreous floaters, even across early stages of the condition, their visual functions are very, very decreased compared to age-matched controls. And this is where it gets really cool. When you look at the micronutrient profile of those patients, we know that they have a deficiency in the bioactive micronutrients, which are what are part of the VitroCap. It's VitroCap in Europe, and it's Vitreous Health in the US.
Right. Okay.
So and I should talk about how that works in terms of the university.
Please do. Please do.
Yeah. So as I said at the outset here, I work at the university, and we will conduct human clinical studies. So the university doesn't own a supplement per se, but we develop the intellectual property. And then through our technological transfer office, there is a license. So that's the conflict of interest. There's two conflicts of interest. One is that there's a license issued from our TTO office that goes to, in this case, it's a Biga Vision, are the company. So a Biga Vision then protect with the university that intellectual property, and in a way that the formulation and the creation of the formulation is crucial, that there is a royalty return back to the university. That's the current disclosure to make.
Okay.
So, and I will work as an educator for the university, and directly I will do consultancy for some of these companies from time to time. Okay. So that's important to acknowledge.
But you say a Biga Vision originally did their own research, and then you subsequently did some within the
A
institute.
Biga Vision worked with some top medical ophthalmologists in Germany, Heidelberg in Germany actually, and they've done significant work there. And their type of studies were kind of patient case studies, expanding, but doing intervention. So they wouldn't have conducted a proper double-blind placebo-controlled trial. Oh, yeah. But our university had a relationship with the owner. We had worked together previously. So when Robert Cookling and Abiga Vision came, we discussed for many years the possibility of trying to use some of the systems that we created with our Macu Prime research, which was the macular pigment research that we did. Could we use some of those same protocols and start working with the Vitreous? But we didn't just do that. We spent a long time designing that. I had to study the Vitreous myself. I had no knowledge on the Vitreous, to be honest. And we partnered then with the Institute of Eye Surgery, which is a hospital in Waterford, and a vitreoretinal surgeon, Dr. Eugene Ning, who does vitrectomies and laser and YAG laser, everything that you would classically do. He was very supportive that we would, for patients that were suffering, that were not suitable or didn't want to have surgery, that we could maybe have a very clean sample to work with for the FLIES trial. And then we did the intervention, and that was a 6-month interventional trial. So we didn't look at any of the outcome measures. We did 3 things in that trial. We developed a questionnaire with our statistician, Dr. Jim Stack, at the time. He's now retired. But Jim helped us develop a vision-related questionnaire, which allowed us assess the impact of having these floaters on patients' quality of life currently and over the previous 6 months. So that was subjective, but there's value in that. So that was the main outcome measure. And then we collaborated with Heidelberg Engineering using the Spectralis system to do 2-dimensional quantification of the opacities. So we could image them. We got the patient to essentially move their eye. We captured all of that, and we could diameter quantify the size of the opacity. So that was a real objective measure. And then we did a visual function measure, which were contrast sensitivity related. How good is the vision today? And remarkably, at 6 months, compared to placebo, which is the best type of study you can do, a double-blind placebo-controlled trial, we saw that about 70% of the patients who were on the active VitroCap, Vitreous Health intervention, we were able to see that there was an improvement in their vision-related quality of life. Now, what was remarkable about this, really, that data on its own would have been interesting, but there would have been a lot more questions. Because we had a quantification data that mapped and matched that perfectly well, we knew that we were correct. And equally when their visual function. So about 70% of the patients at 6 months had a measurable improvement in their subjective, objective, and visual function related quality of life. And we still have this 30%. I would like to have the decorum and respect to people that suffer with vitreous floaters to say that this isn't a silver bullet, and I get the trauma that this condition has for patients, because I actually suffered myself, and I can tell you about that in a minute, but I've had very positive reply, personally, directly, email, and very negative reply. I've had people tell me this is not good, it hasn't worked. And but I'm very pleased to see that, you know, even some cases where patients in the first 3-6 months haven't had benefit, doing it longer has been. And I have, for full communication and disclosure, I still have patients that have come back to me to say this just hasn't worked. So
Yeah, sure.
yeah, and that's just a statement of fact.
Yeah, that's fine. I mean, I'm taking VitroCap myself at the moment, so still ongoing. So that's fine. I mean, but there's maybe a couple of points. Just a quick one, just for myself, really. I think the Heidelberg, obviously, are well respected, known instrument maker and what have you. The module for I mean, obviously they're like slit lamps, and OCTs are modular systems, aren't they?
Yeah.
Is the module for kind of I suppose quantifying floaters, is that commercially available,
I
or
believe
is that
that
a custom?
I believe that they've developed one.
Mhm.
And I think there's some other organizations that are working on that. The one we used was custom built.
Right, got you.
I'm using previous, it was Image J software that we essentially got a wide angle lens,
Yeah,
and we were able to create a movie, and we were able to ask the patient to follow a basic instruction, essentially to move the right, to bring the floater into. And what we did with this, so it was custom, that's to answer your
yeah,
question, but we spent a lot of time checking the validity of that. We did interclass correlation measurements over 3 repeat tests
yeah,
to see that we were
hmm,
getting the same answer.
yeah.
And
Okay,
we were, you know, it was 0.998 or something, extremely high in terms of our ability and the sensitivity of what we were doing. So we full confidence in that.
oh,
What I found
excellent.
interesting about the objective measure
Hmm.
was, and in a couple of the patients, we see that the opacities, not only in the placebo group, not only significantly remain in that they don't get better, they actually got significantly worse, even at 6 months. So I think this is a progressive disease. Maybe our brain is adjusting to the trauma that it's contending with, right?
Hmm.
That's what the brain does. But yes, so that it's not something you can buy off the shelf.
Yeah,
You can measure visual function. You can. My understanding is that Abiga Vision will make for any optometrist the questionnaire available. Very quick, basic questions that you could ask your patients, and then they can hopefully change. You know, there's other things that patients should do as well, right?
hmm,
Lifestyle related. You know, that could help. You
yeah,
know,
yeah,
excessive
yeah,
alcohol consumption, all of these things appear to be related to, you
yeah.
know, the effect of the floater suffering.
Okay, got you. I mean, question I'll ask, just to, I suppose, put to bed some of the I think some of the cynical kind of thinking that might be about the effectiveness of, whether it's in terms of floater treatment things, whether it's talking about VitroCap N, or proteolytic enzymes like bromelain, and I suppose the thing that people
Pineapple,
think. Sorry.
the
I suppose
pineapple
that,
study.
yeah, exact pineapple study. So the thing that people, I suppose, struggle to get their head around, and this might include professionals as well, is this idea of um, you know uh, uh, micronutrients penetrating into the vitreous. Do you have a kind of mechanism that you think that happens by? Because I
Yes.
remember, I mean, I found some work by, I think, Maurice,
Yeah.
and that kind of was the thing for me that made me actually realize, actually there is some kind of data to support this.
The bit I struggle with the enzyme piece is that if you're a counter mechanism would be that if you're putting all these enzymes that are gobbling up the proteins into the vitreous, is that going to
Mm.
create a different problem? But it
Yeah.
appears to be kind of selective to the conglomerates in play. So
Mm.
I don't think it's a singular mechanism. I think it's multifactorial in terms of,
Mhm.
I think, enhancing the antioxidant harmony, if you like, within the vitreous allows a correction and a reconfiguration. And I think it goes back to that point on opacities. So if you think of and light being allowed to do what we want it to do. So I think it comes back to optics and wavelength. And I think very small changes by enhancing the antioxidants, just reducing that kind of stress, if you like, of oxidative stress in the vitreous, can have a major effect on the harmony of the vitreous, which means that the wavelengths are kind of recalibrated. So I think it comes back to that. You know, these antioxidants also have anti-glycation properties. So again, reducing issues related to glycation, the addition of these sugars to the change in the configuration, and so on, just cleaning it up. It's making it healthier.
Yeah.
So I can't, you know, Robert Cookling only said to me the other day, we were speaking in France because I was presenting at that conference, and we discussed this exact point. And we both feel that there's more work to do to kind of understand and discuss and study the mechanism, because I think that's important. But we know that adding an antioxidant to a tissue that's localized within that tissue can give multiple benefits. We see this in the macula, and it could be a you know, an additional benefit there too in that regard. So I think there's many, and I don't think it's obvious, and I think there probably is more work to be done mechanistically.
Yeah, that makes sense. I mean, many of the conditions that we kind of look at, whether it's a dry eye, like say macular degeneration, many of them are multifactorial, aren't they?
Yeah.
Rather than being one, you know, one single approach and one single way of doing it. I mean, I used to wonder whether is it hyaluronic acid, whether, because I think was there a link between the levels of that and degeneration of the vitreous?
Yeah.
And
And
whether,
again,
if that is the case, if we're seeing a lot of young, you know, it may be, I don't know if it's actually the case, but it seems like we're seeing a lot of younger people developing floaters, and whether there is, you know, something in that, and perhaps some premature aging effect caused by hyaluronic acid levels and things like that. I mean, I don't know if you have any thoughts on that.
my only thoughts on that, you know, I haven't measured hyaluronic acid, you know, and I'm interested in even the study of the collagen fibers, and there's lots I'd like to do. But what I do know, and you mentioned that younger people are suffering, and typically people that are really suffering with floaters are not your classic 60, 70-year-old patient. It's typically people in their 30s, 40s, 50s that are really suffering because there's this quality of life gone. I think one of the issues is that the access that we have to micronutrients in today's world is a big problem, not just for the macula. It's clearly a problem for general health, cardiometabolic disease, you know, diabetic retinopathy, all of these. It all comes back to foods. It all comes back to how we live. It all comes back to what's happening in the food industry. And unfortunately, Martin, it's not a very good picture. It's not a
Totally
very,
agree.
like, I measure carotenoids for a living. And we measure vitamin C now, one of the primary components of VitroCap and Vitreous health. And the foods that we're consuming now are so poor in terms of, you know, the stability and the quantity. Like, you take carotenoids, for example. You know, everyone would like to say, well, eat the rainbow plate and have all. Of course, this is really good advice, and as a nutritional biochemist, that's what I should be promoting, and I do. But I'm also very clear that on its own is not going to be enough. We're farming all these plants in a way that we're making it very easy for plants to grow, which means that the plants won't produce the carotenoids. So carotenoids and bioactives are produced in plants to allow plants grow in stressful environments like normal farming. In a world where we over-farm because we need a lot of food for people, and we select particular crops, and we use pesticides, and we store in a certain way, by the time it gets to our fork, we're really in trouble here. And that's why I'm really comfortable to say to eye care and to say to optometry, you have a role to play here. In primary eye care, you're the gatekeepers to vision. You have to take the burden off medical ophthalmology, and you have to stand up to medical ophthalmology. You have to work with medical ophthalmology. And what I mean by that is, you're all trained, highly trained on working with patients, working with vision. This is what you have to do, therefore. So there's a world where there's this, work that's done before. I mean, if you look at what happens in medical ophthalmology, it's not about prevention. It's not about knowing about nutrition or knowing about the various, anti-glycative, antioxidant, enzymatic micronutrients of the vitreous. It's about, can I cut this? Can I inject? Can I extract? And can I move on, please? And by the way, if you look at what happens in ophthalmology, and this will be controversial, but that's okay. We wait, if you look at standard of care, we wait until a patient goes from being a little bit sick to being very sick before we treat them. Macular degeneration.
Yeah.
Still 90% of ophthalmologists won't talk about nutrition or macular pigments, even though
Yeah.
we know that they're highly effective,
Yeah.
because they'll wait until a patient hits level 8, 9, and 10 on the ARID scale, and those with
Sure.
cardiovascular degeneration that they'll inject. So it's test, retest, retest, and now you're sick enough, come to my clinic. And I'm
Yeah.
not being critical of medical ophthalmology. This is the system they work within.
Yeah.
They'll only work with licensed drugs like anti-VEGF therapy in a drug that costs €2,000 for an injection that we have to give an elderly patient 10 times a year. That's
Yeah.
standard of care. That is the standard of care.
Yeah.
That's Health 2.0. That's not
Sure.
correct. Health 3.0 is where you can play.
Sure. Yeah.
And that's where where you do what you're doing, which is, begin by being skeptical, do the work like you've done, study the papers, ask the hard questions, and then say, right, do we have a body of evidence here that we can trust, that's scientific and evidence-based? Do we have access to nutrients and information that have a validity, that have, are they part of a certification program? I think you mentioned to me in one of your communications, are all supplements the same? They're absolutely not. And I would urge everyone, if you are that doctor that has studied this and wants to make this an option for your patient, the best advice I could give you is to understand the particular formulations that have been tested, because there's a lot of counterfeit formulations out there. And I've tested a lot of these and they miss their label claim. So in other words, if you let the patient make their own decision, they may buy something in a health store that
Sure. Yeah.
doesn't that has no bioactives or doesn't meet the bioactive claim.
Yeah.
So and we've even seen organizations trying to copy the technology from Southeast Technological University for commercial benefit. So, Abiga Vision and our TTO office deal with that. But it's really important that the patients and their doctors get access to the scientific inventions that are the supplement formulations that are tested.
Yeah.
And I promote Supplement Certified, which again, I have a conflict of interest there in that I'm a founder. It's a spin out company from our university, and that whole organization is developed and designed to work with commercial companies like Abiga Vision, like MacuHealth, many others. That put their supplements on quality testing programs to make sure they're stable. So that's important.
Yeah. Yeah. Thank you. That's really helpful. I mean, macular health is something I'm really passionate about, actually, and I think it's obviously protecting the macula is, the most important thing really you can do for an individual's vision. I mean, many eagle-eyed viewers of my channel will probably see one of the instruments I have in my backdrop is actually an old M-Pod machine that I used to have from back in the day. So macular pigment optical density measuring, and we used to do that in practice, and I could never understand why that just never became a thing. And I think you've been developing, or I don't know how much you've been involved in that, in an alternative way of doing that. Is it
Yeah.
life meter?
Yeah, so flicker photometry is what you're using, the MPOD, and I've used it, and flicker photometry can be great. It's difficult. I think to answer your first question, flicker photometry is difficult to implement in the clinic setting because it's a psychophysical test, and you need to be very good at doing. And you need to use do you do a peripheral measurement at 7 degrees, or can you remember?
It's not. No, it's not something we do routinely now.
Yeah.
But as I said, but back in those days, I can't remember exactly the procedure
Yeah.
we used to do, but we,
Okay.
we had, I mean, you're talking about a decade or so.
Okay. Yeah, no, I mean, and I was very supportive of the concept that eye care and optometry would measure macular pigment. That was wonderful. But I agree with you. It wasn't successful. And the reason being is, it's a subjective test. And if it's not done right, you can have high variability. And if you don't do a peripheral measure, you have a problem. To answer your question about the life meter measures carotenoids in the skin. And 7 or 8, depending on your diet, 7, 8 carotenoids in the skin, and which includes the carotenes, beta carotene. It includes lycopene. It includes lutein, zeaxanthin. Right. So the point is, if you were to measure the life meter, is a spectrophotometer, which basically is a scientific device that measures light. And the inventor of that is a scientist who I know for a long time called Werner Gellerman out of Utah. And he commercialized his technology. And he's partnered with an organization called Macular. They're a US organization, and they have the Macu Prime formulation in Europe, which is the formulation tested at our university. And it's a really great screener of carotenoids. And we've used it in all of our clinical trials in parallel with the Spectralis. We use dual wavelength autofluorescence to quantify the macular pigments. We also correlated it against blood HPLC measurements of lutein, zeaxanthin. And so when I give a patient MacuPrime supplement and it goes up, the skin measurement goes up in concert with that. It's a really good. The nice thing about it is, it should be viewed as a screener because that's what it is, but it's very easy to do. It's very reproducible. So if you wanted a tool in your eye care practice that gives you a measure of carotenoids that are relevant to your eye and your brain, it's fantastic. And it's essentially taking advantage of 20 years of science that we correlated these type of measurements against the more refined, sophisticated macular pigment measurements. So I think it's a much better opportunity than doing psychophysics in the clinic. It's something in the US, for example, that they're doing front of house. So even the research techs or the administrators in the clinic are doing this in the waiting area, and then by the time the patients get into the eye doctor, this information is available, and it allows for a more fruitful conversation with the patient. And then if the patient decides that they want to go on a supplement to try and optimize the health of their eye, and that's the other thing I'd say to you, Martin, for the macula, because you said you're fascinated and interested in the study. My lecture last week in America spoke to the point that I need optometry. And I suggest that optometry changes how they think about nutrition of the eye. And instead of using it to treat, because it's not a replacement for treatment, macular degeneration patient, you should use it in the exact way you're not using it. And what I mean by that is, don't wait for patients to have sick eyes before we talk about optimizing the health of the eye. I mean, in addition to spectacles, which is what optometry does, we make sure that everyone has the best refraction they can to give them, the best optical system that they have. The discoveries in macular pigment nutrition of the macula are major, and they are the only next way, in addition to this, that we found out a way to make vision better for your patients. So macular pigment enhancement for all of your patients is truly valuable.
Yeah, absolutely. And I guess just to break it down for those who listen that may not know what we're talking about, I guess it's the idea then that, you want to make sure that we've got a good density of these nutritional carotenoids at the macula, so lutein, zeaxanthin and mesozeaxanthin, because they provide protection to stop the retina degenerating and the problems associated with that. So then I suppose what you're saying is that, we should be looking at it from a preventative point of view, screen people, because these kind of devices are easy to screen people to check what their level of serum carotenoids are, and that should correlate quite strongly to the macular pigment density.
But if you simply want to make your patient's vision better, the Crest Normal trial with
Yeah.
Macuprime demonstrated this. You know, we took people with really healthy vision, we optimized their optics, and then we enhanced their macular pigments. And we increased their contrast sensitivity, improved it by about 15%.
Mm.
You know, I'm now working with Olympic athletes all over the world, including a major trial we're just finishing in Singapore with the Sports Institute of Singapore. You know, macular pigment and this type of enrichment is crucial to performance. You look at athletes; they're not really thinking about bioactive carotenoids or you know, enhancing their vitreous health or anything like that. They're thinking about their protein, their sleep, all of these great things, and they're actually neglecting the role of the bioactive. If I was to say to you, Martin, you know, what's good about the coloured plate? What's good about the Mediterranean diet? Imagine if we could identify the good stuff in those foods beyond the fiber, the protein, and everything else. And the answer is we have. That's the science of today. We have, you know, the macular pigments we work with come from Mexico, from marigold flowers. You know, there's 700 carotenoids in the world, in nature, more now probably. There's 50 in a typical diet. There's less than 20 in your blood, and there's 3 in your eye. And we've been able to identify those. And so that's very exciting that we've been able to do that in this time. And eye care is benefiting from it. But you must be sure you're using a supplement that has an efficacy, a stability, a quality. These are the key messages I would have for your listeners.
Yeah, fantastic. Thank you so much, Professor Nolan. Really appreciate your time. You've given us quite a lot of time.
Pleasure.
And it's been a fascinating discussion, and you know, a lot of takeaways there. So really thank you so much for taking time to be here, and I'm going to let you get going
Yes,
because I'm
sir.
sure you got a lot on today.
Yes, sir. Thank
Yeah,
you,
thanks
Martin.
so much. It's been my
Nice to
pleasure.
speak
Thank
to
you.
you.
And
God
you.
bless
All
you.
right, bye now.
Take
Bye.
care. Bye bye.